You will now be placed into the conference.
Some of you, Vicky has been involved in cancer-associated thrombosis ever since I've known her, more than 10 years ago. She has completed training in internal medicine and has done a master's studies in epidemiology and is actually very interested in the specific aspects related to the etiology and epidemiology of cancer-associated thrombosis. So she is an expert in this field. She's an associate professor of medicine at McGill, and she's the director of the Division of General Internal Medicine there. The objectives for tonight are to recognize the principles of managing cancer-associated thrombosis. We are going to discuss some anticoagulant options relative to new clinical evidence that we've seen in the last year. And we will use that new evidence to discuss brand new guidelines that have been discussed amongst different Canadian experts over the past year and discuss with you how this is going to be possible for you to implement that in your practice. So I have a few housekeeping notes that I want to pass along. You should have had a copy of the slides on a PDF format if you ever have a difficulty following the WebEx presentation. And you might have seen that in the upper right panel of your browser, there's a chat box that you can click and access the chat windows, and that's going to put you in a position to ask questions as we go along. You will also notice that there's a send to roll-down menu that you can use to actually send either a private question to Vicky, or I suggest that you use the everyone selection so that everybody can see your answer, and I'm sure that Vicky is going to spot that as she goes along, and she can answer your question as we go. So with that, I'm going to pass it to Vicky, who's going to give us her talk.
Great. Thank you, Normand, and thank you, David. So I'm very excited to present tonight's featured presentation on anticoagulant options for the management of acute cancer-associated thrombosis. So I'd like to also thank Thrombosis Canada for giving me the opportunity to present this important work. So on the slide you see now are my conflicts of interest noted. I'll pause just for a minute so you can see that. Okay. So I should mention at this point in time the support received for this important work. This program has received financial support from Sanofi Canada in the form of an educational grant. Potential for conflict of interest. All funding for this program was arm's length, and the content was developed by an independent committee of Thrombosis Canada members. The presentation does include reference to medications which the Sanofi markets in Canada. Moreover, the content for this program was developed by a scientific steering committee from Thrombosis Canada. All faculty have been directed that any recommendations involving clinical medicine are to be based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the CME or CPD activity in support or justification of patient care recommendations conforms to the generally accepted standards. And here we have the planning faculty for this CME or CPD activity we are participating in tonight. And you note there that included amongst my colleagues are indeed Normand Blais, with the program chair being Marc Carrier. Others included Mary De Carolis, Eddie Lang, Agnes Lee, and Laurie Sardo. So the learning objectives for tonight's presentation, we hope that the participants will be better able to understand the risk of venous thromboembolism in the cancer patient population, discuss best treatment options for cancer-associated thrombosis, recognizing cancer subgroups and bleeding risk, define when to consider hospitalization and how this impacts VTE risk, discuss risk factors associated with an increased risk of VTE and major bleeding episodes in patients with cancer-associated thrombosis, and identify best risk reduction strategies for recurrence of cancer-associated thrombosis. Examples of possible strategies could be patient education on adherence, looking at signs and symptoms of recurrence and bleeding, and better informing our patients about follow-up. So we'll begin with the content. First, I'd like to define the terms used today. So obviously, thrombosis refers to the local coagulation or blood clot within the circulatory system. Venous thromboembolism is a term used to describe the blood clot that can occur in the deep veins of the leg, also called DVT, blood vessels of the lungs, noted as pulmonary embolism or PE, in the arms, especially if a catheter is in place for giving chemotherapy or drawing blood, in the organs, such as splenic vein thrombi, and moreover, the term cancer-associated thrombosis is specific to blood clots that occur in patients living with cancer. So, as we know, cancer-associated thrombosis is indeed a frequent and important complication. Patients with cancer have a 4- to 7-fold higher risk of venous thromboembolism than patients without cancer. Venous thromboembolism and thrombotic complications are the second most frequent cause of mortality in patients with cancer, second to advancing cancer itself, and tied with infection or infectious complications noted in cancer patients. And moreover, fatal pulmonary embolism is 3 times more common in cancer patients than in patients without cancer. So quite an important problem. And why does it happen in cancer patients? Well, if we look at the classic Virchow's triangle proposed by Virchow many centuries ago, looking at risk factors that could impact on someone's risk for thrombosis, they can be categorized as was by Virchow, by venous stasis, blood hypercoagulability, and vascular injury. And if we look at possibilities in the cancer patient that can explain their heightened risk for thrombosis, if we look at venous stasis, one of the clear risk factors that come to mind include immobility or bed rest, such as during a hospitalization or following surgery, or with the extreme sort of declining health that can occur in cancer patients where they become less mobile. Tumor compression on vessels could also be a reason. When we look at blood hypercoagulability, the malignancy itself can be associated with a heightened risk for a hypercoagulable blood through, for example, procoagulant tumor-releasing factors. Hereditary risk factors can also impart an increased risk through this mechanism, and increasing age could also impact on this risk. And finally, vascular injury is something that we note can be a medium or a pathway to increased risk of thrombosis in cancer patients, and this could be vascular injury from surgery, from the chemotherapy itself, from the central catheters that are used to deliver therapy and or draw blood, trauma, and finally, intravasation of cancer cells into the bloodstream. So when does cancer-associated thrombosis occur? Interestingly, several epidemiologic studies have shown that cancer-associated thrombosis most frequently occurs in the first 3 to 6 months after cancer diagnosis. And so there seems to be a heightened incidence at that period of time, but it can't be observed at any time during the course of cancer patients' therapy. Moreover, we know that during periods of chemotherapy, there seems to be a heightened risk or an increased risk of venous thromboembolism that can vary anywhere from 2 to 6-fold increased risk. So if we went first into looking at how we treat cancer-associated thrombosis, and then we'll explore following that different cases that we have for you tonight to discuss, how to manage specific sort of situations. We'll try to summarize the current guidelines on treatment of cancer-associated thrombosis, and then look at the specific studies. So when we look at the current guidelines, and by current guidelines, I mean the ASCO guidelines, Thrombosis Canada, the Canadian Consensus Expert group that came together and also proposed treatment strategies for patients with cancer-associated thrombosis. We note that they recommend low molecular weight heparin for the treatment of established deep vein thrombosis and pulmonary embolism, as well as for use in the long-term secondary prophylaxis for at least 6 months of duration. However, these guidelines have not been, as of yet, formally updated since the introduction of the direct oral anticoagulants, and their use is now being steadily, increasingly studied in the patients with cancer and active thrombosis. And so it's interesting to note that how these new agents will be considered in the new guidelines, and we'll explore what, in the next few slides, the possible implications for these drugs in cancer-associated thrombosis management. So here we have some of the current guideline recommendations above and beyond ASCO, Thrombosis Canada, and the Canadian Consensus Group. We also have the European Society of Medical Oncology and the National Comprehensive Cancer Network. And if we look at the initial treatment, we note that low molecular weight heparin is the preferred option over other modalities consistently across the different groups. And when we look at secondary prophylaxis, i.e. beyond the initial 5 to 10 days, we note once again that low molecular weight heparin is recommended or preferred over the other anticoagulants, primarily vitamin K antagonists, and this for a duration of at least 6 months, or while the cancer is still active. And most of these recommendations are based on now older studies that compared low molecular weight heparin to vitamin K antagonists. And we note there are 5 different studies that have addressed the impact or effect of low molecular weight heparin on cancer patients with venous thromboembolism, looking at the risk of recurrence as well as major bleeding as compared to vitamin K antagonists. If we look, the studies range from small studies, anywhere between 140 or so patients, up to the largest study being the CATCH study, which included over 850 patients or so. And we see that the seminal study, that was the first study to really show that low molecular weight heparin was more effective and safer than vitamin K antagonists for the management of cancer-associated thrombosis, was the QUAD study that compared dalteparin versus an oral anticoagulant, primarily vitamin K antagonists. And we note that following that, the CATCH study was the second largest, which showed a trend towards improved risk of recurrence as well as major bleeding with tinzaparin. And the smaller studies that included the Kaplan-Meier study looking at enoxaparin, as well as the Octo study that also looked at different dosing of enoxaparin. There seemed to be a trend towards improved risk of recurrence with low molecular weight heparin, although these studies were quite small to give definitive conclusions. So what has the implication been with the new data on the direct oral anticoagulants? So recently, studies, as you know, have been assessing the efficacy and safety of direct oral anticoagulants in the prevention and treatment of CAD. And they have been published primarily looking at direct oral anticoagulants versus vitamin K antagonists, and there have been quite a few studies in the past 10 years that have specifically looked at this comparator group. However, more recently, we've had 2 studies that have looked at a direct oral anticoagulant versus low molecular weight heparin, and specifically this has been in the cancer patient population affected with venous thromboembolism. When we look at the initial studies that compared DOACs versus vitamin K antagonists, there have been subgroup analyses of these acute treatment trials for the management of VTE, which, looking at the subgroup analysis of patients with some sort of cancer, whether it's active cancer or quiescent type of cancer or a history of cancer, they also seem to suggest that direct oral anticoagulants have similar efficacy and safety profiles compared to vitamin K antagonists among cancer patients. Now, these are the subgroup analyses of the studies looking at DOACs, vitamin K antagonists, and so there were very few cancer patients included, specifically very few active cancer patients. And the thinking is that these patients seem to have a low risk of recurrent VT and major bleeding. By definition, given that these were a small group of patients likely being enrolled into a study where it was felt that their cancer was semi-quiescent and not contributing to a high risk of thrombosis. So if we actually look at these subgroup analyses specifically, and we look at the meta-analysis that is noted here of DOACs versus vitamin K antagonists in cancer patients with acute VTE, we have the Amplify, the Einstein DVT, the Einstein PE, the Hokusai and the Recover 1 and 2, with the whole gamut of direct oral anticoagulants, specifically apixaban, rivaroxaban, edoxaban, and dapigatran. And we see that although when you look down at the different risk estimates, specifically noted as an odds ratio, we see that there is a odds ratio that is in favor of the direct oral anticoagulant as compared to vitamin K antagonists, but the totality shows that the confidence intervals do cross unity, and so although there seems to be a trend, it's not a statistically significant estimate of effect. Nonetheless, this points to one could conclude that they at least seem to be as effective to vitamin, not inferior to vitamin K antagonists in the management of acute venous thromboembolism in cancer patients when looking at the risk of recurrence. When we look specifically, again, at these meta-analyses, specifically of the DOAC versus vitamin K studies in subgroups of cancer patients with acute VTE, and we look at major bleeding in panel A, and then in panel B, we're focusing on clinically relevant bleeding. When we look at major bleeding as defined by specific criteria put forth by the ISTH, we also note that there doesn't seem to be a statistically significant difference between a DOAC and a vitamin K antagonist, at least when looking at the subgroup analyses of these studies. Similar conclusion can be made when specifically looking at clinically relevant bleeding. Once again, we do not see a statistically significant difference, but we have to highlight again that these are data from subgroup analyses where the intention was not to specifically look at cancer patients. And moreover, we're comparing vitamin K antagonist usage, where many people would say that it's not the standard of care in for cancer-associated thrombosis, and rather low molecular weight heparin is the standard of care. So when we look at, in fact, meta-analyses of yet another low molecular weight heparin and DOACs to VKA in cancer patients with acute VTE, when we look at panel A, looking at the risk of recurrence once again, looking at low molecular weight heparin versus VKA, we have there all the classic low molecular weight heparin studies that were done for cancer-associated thrombosis comparing to vitamin K, and we highlight there, for example, the QUAD study, the LIGHT, the AUSTINOX, the CATCH study, the CASINOX, and so on. We see that the summary estimate shows to be in favor of low molecular weight heparin when looking at the risk of recurrence. And similarly, when we show the DOAC studies comparing DOAC to vitamin K antagonists, specifically in cancer subgroup patients, we see a trend towards favoring the DOAC in these studies. Similarly, when we look at major bleeding, panel A, looking at low molecular weight heparin versus vitamin K antagonist, we do not see any difference between low molecular weight heparin and vitamin K antagonist in the totality of a summary estimate from this meta-analysis, and similar estimate is seen, or similar conclusion can be made when looking at the DOAC versus vitamin K studies. So just before I move on, what these different meta-analyses are showing in conclusion is that indeed we do not, up until the Hokusai VTE cancer trial that I'll be discussing next, did not have studies that directly looked at low molecular weight heparin versus a DOAC, but we could borrow from the DOAC versus vitamin K antagonist studies that were done in the general patient population affected with VTE, and at least look at these subgroup analyses, and then combine these different subgroup analyses to then do these meta-analyses, which seem to show that there seems to be a trend towards the DOACs decreasing the risk of recurrence with a similar risk in major bleeding. And so given this signal, it only behooves the next studies to be done, which were specifically looking at direct oral anticoagulant versus low molecular weight heparin, specifically in a cancer patient population affected with acute venous thromboembolism. And so we then are able to answer the naysayers from these previous studies where the often argument was that we were not comparing to the standard of care, and moreover, we were not using an active cancer patient population. All that has changed with Hokusai VTE cancer study, and it's presented here. I briefly will describe it. The study design is an open-label, non-inferiority trial with 1,046 patients with cancer who had acute symptomatic or incidental VTE. Treatment was as follows. The interventions included random assignment of patients to receive any low molecular weight heparin for at least 5 days, followed by edoxaban at 60 milligrams once a day, or dalteparin at 200 international units per kilo for the first month, followed by dalteparin 150 international units per kilo daily. And this was for at least 6 months and up to 12 months. So physicians enrolling patients into the study were encouraged to keep their patients for at least 6 months on therapy, and thereafter it was up to the physician discretion whether or not treatment continued up to a maximum of 12 months. There's a note here for edoxaban. There was a reduced dose of 30 milligrams that can be used in patients with creatinine clearances of 30 to 50 mils per minute, or body weight of less than 60 kilos, or those receiving concomitant treatment with potent P-glycoprotein inhibitors, which are medications impacting on the B-glycoprotein gut transporter, which can then impact on the absorption of edoxaban. So the primary outcome was interesting. It was a composite outcome of recurrent venous thromboembolism or major bleeding during the 12 months after randomization, regardless of treatment duration. So the primary outcome was first to either a recurrence or major bleeding, both thought to be quite important in a cancer patient, in cancer patient management and treatment. So here we have a pictogram or figure that shows the scheme of randomization. Just to let you know that the VT had to be objectively confirmed, and there was an attempt to stratify patients for randomization based on bleeding risk, and there was a bleeding risk score that was provided, dose adjustment, and in the end, 114 sites in North America, Europe, Australia, and New Zealand were included in this study. We note once again that treatment was up to 12 months, but at least 6 months, and there was independent blind adjudication of all suspected outcomes. And moreover, there was a severity of major bleeding at presentation that was also adjudicated. This was a grading system that was applied to every major bleeding episode, and this was also adjudicated. So here we have the classical Table 1, which describes the baseline characteristics. You see that in general, the patients were well balanced between the two groups, with around 53% of patients being men in the edoxaban group versus 50% in the dalteparin group, median age of around 64 in edoxaban and 63 in dalteparin. And what I'll highlight is that most patients had several risk factors for bleeding, more than one. And you see there that 20% of the edoxaban group versus 23% of the dalteparin group had at least 3 risk factors for bleeding. Not surprising that active cancer was noted in 98% of the edoxaban group and 97% of the dalteparin group. And at least almost 3/4 had received cancer treatment within the previous 4 weeks. Of interest, the CRAN clearance was between 30 and 50 in 7% of the edoxaban group and 7.3% of the edoxaban group and 6.5% of the dalteparin group, and less patients on with platelets that were between 50 and 100. And in the end, about 23% of patients were on the lower dose of edoxaban, and there was also a group that ended up being on a lower dose of dalteparin during the therapy, although that was also dependent on physician preference. The different chemotherapy agents used are noted here. They could receive more than one anti-cancer drug at the time of enrollment, but treatment did not include anti-cancer therapy initiated after randomization. So patients' treatments were documented at baseline, and these were the treatments that were documented at baseline at the time of enrollment. And so you see that most of the therapies were anti-metabolites or platinum-based chemotherapies, and less so of the other agents. So these are the results. We have the classic Kaplan-Meier cumulative event rate, Kaplan-Meier curve for the primary outcome of the composite of recurrent VTE or major bleeding. And we see that there was no difference in the estimate of effect. Specifically, the hazard ratio was 0.97 with a confidence interval around 0.7 to 1.36. And so edoxaban was not non-inferior to dalteparin when it came to the primary outcome, which was the composite of either a recurrence or major bleeding. And when we look specifically at these event rates, we see that in recurrence or major bleeding occurred in 12.8% of patients on the edoxaban versus 13.5% of patients in dalteparin arm, once again for that hazard ratio of 0.97, reaching the non-inferiority set limit with a p-value of 0.006. And the conclusion that was provided was that oral edoxaban was non-inferior to subcutaneous dalteparin with respect to the composite outcome of recurrent thromboembolism or major bleeding. We can also note here the authors provided a separated primary outcome, meaning as a secondary analysis, they looked at specifically the secondary outcomes of recurrent VTE, and as a secondary analysis, they looked at major bleeding. And when we look at the far left at recurrence of VTE, we see that for this outcome of recurrence, the hazard ratio was 0.71 with a confidence interval of 0.48 to 1.06, barely crossing unity, where dalteparin seemed to have edoxaban seemed to have a trend toward improved a risk of recurrence of VTE. When we look at major bleeding, we now see that the hazard ratio was 1.77, with a confidence interval of 1.03 to 3.04, and thus crossing unity with a statistically significant, therefore, confidence interval reporting around that hazard ratio, where there was a higher risk of major bleeding with the edoxaban group compared to the dalteparin group. When we also look at, as many folks noted earlier, patients were treated for a minimum of 6 months, and thereafter it was left to the discretion of the physician whether they were continuing on for how long they would continue, up to a maximum of 12 months. We do know something interesting is that treatment duration or median treatment duration did differ between the two groups. And in fact, the edoxaban group stayed longer on therapy than the dalteparin group, 211 days of therapy for the edoxaban group versus 184 days for the dalteparin group. And right below that, we see that the patients who completed study treatment at 12 months, there were more patients in the edoxaban group versus the dalteparin group. And when they looked at the number one reason for discontinuation, it was driven by patients and patient preference to stop therapy. So it seems that patients in this particular study, the Hokusai Cancer VTE study, more patients in the dalteparin group as compared to the edoxaban group were stopping therapy earlier. We here have the exact point estimates for recurrence and major bleeding separated out. And when we look at the rate of recurrence of VT specifically in the edoxaban group, it was 7.9% versus 11.3% in the dalteparin group. And we see there what the hazard ratio is of 0.71. Most of it was actually driven, as you can see, equally between recurrence of DVT and recurrence of P. And when we look at major bleeding, we now see that major bleeding sort of flipped, where 6.9% of the edoxaban group experienced a major bleeding event versus 4% in the dalteparin group, for a hazard ratio of 1.77, meaning a 1.7-fold increased risk for the edoxaban group as compared to the dalteparin group, with a confidence interval that's fairly tight around that 1.77. When we look at clinically relevant non-major bleeding, we see once again there was a tendency for more clinically relevant non-major bleeding in the edoxaban group than the dalteparin group, 14.6% versus 11.1%. Deaths seem to be fairly equivalent between the two, with 39.5% in the edoxaban group versus 36.6% in the dalteparin group, reflecting a patient population that has a high risk of death, by definition, given that all these patients had active cancer, with many of them having metastatic disease. There was, in the Hokusai Cancer VTE study, when they looked at specifically the types of bleeding and where most of the major bleeds were occurring, were in fact GI bleeds as compared to any other type of bleed, such as intracranial bleeding, for example. And when they looked at specifically who was getting these GI bleeds, there seemed to be a predominance of GI bleeding in patients with GI cancer. So when you looked at the GI cancer in each of the groups, there was 136 GI cancers in the edoxaban group versus 125 in the dalteparin group. and you see that 18 or 13.2% had a GI bleed in the edoxaban group versus 2.4% in the dalteparin group. So there seemed to be a signal that the major bleeds were mostly GI bleeds and mostly in patients with GI malignancy. And in fact, upper GI bleeding was the predominant site rather than lower GI bleeding, even in the patients with lower GI malignancy, such as colorectal cancer. It seemed to be that if there was going to be GI bleeding, it was mostly going to be upper GI. So here we also show survival results. Once again, as I mentioned earlier, around a quarter of the patients died during this study. So the 6-month survival was 67.8% in the edoxaban group versus 68.7% in the dalteparin group. 6 deaths in each group were related to VTE or bleeding. There was no objectively confirmed fatal PEs. And of the patients with recurrent PE, 1% of patients in the edoxaban group and 0.6% in the dalteparin group had unexplained death, where PE could not be ruled out as the cause. So that was the Hokusai Cancer VTE study. It was a study that came out at the same time, or was presented at the same time as another study, a pilot study, however, that now looked at rivaroxaban versus dalteparin. So now we still have the same low molecular weight heparin agent, but this time we're looking at rivaroxaban. And this was a smaller study. Indeed, it was meant to be a pilot study to inform investigators of feasibility to move on to a larger study. It was a prospectively randomized open-label, multi-center pilot phase 2 study. 406 patients with active cancer with symptomatic DVT and or any PE and a fairly good ECOG status were approached. They were randomized to rivaroxaban, 15 milligrams twice a day for 21 days, followed by 20 milligrams once a day, or dalteparin with the traditional regimen noted there, 200 international units per kilo for the first 30 days once a day, followed by 150 international units per kilo once a day. This time, treatment duration was specifically defined to be 6 months. And here, the primary outcome was to assess VT recurrence in cancer patients with a first VT treated with rivaroxaban or dalteparin, and also to assess rates of major and clinically relevant non-major bleeding. So this was the pilot design of the study design of the pilot study. 530 patients were approached and randomized to rivaroxaban versus dalteparin. We note, though, the second part of the study, at 6 months, there was a second part. There was a second randomization that would occur where all patients with residual vein thrombosis on a Doppler were randomized to rivaroxaban versus placebo for an additional 6 months. So these were patients who had suffered a deep vein thrombosis and at the end of 6 months underwent a Doppler ultrasound. And if they had residual vein thrombosis, they were then randomized to rivaroxaban versus placebo for an additional 6 months. All patients with P were automatically randomized at 6 months into this second part of the study. Unfortunately, they did not have enough patients, or it was very difficult to have a pool of patients available at 6 months to undergo the next randomization phase, and so this part of the study was dropped eventually. And as a result, there were changes to the study design, which have impacted on some of the inferences that can be made as a result of this study. Moreover, during the course of the study, it was noted that the DSMB, the Data Safety Monitoring Board, noted early on that there was an excess of GI bleeding in patients with GI malignancy, and so patients with GI malignancy were excluded from this study. So there were changes made above and beyond the fact that this was a smaller pilot study, that have to be considered when looking at the data. Nonetheless, what can we learn from this? We note again, amongst the patients that were randomized from rivaroxaban to dalteparin, that once again, around the median age is around 67, similar to the Hokusai cancer study. 48% were male versus 54% in the dalteparin group. Metastatic cancer, 58% had metastatic cancer in this study. Much more patients had metastatic cancer in the Hokusai cancer VTE, not by much, but a bit more. Active cancer treatment was being received by 69% of the rivaroxaban group versus 70% in the dalteparin group. And if we look at the bottom, the qualifying VTE, it was almost half-half were symptomatic VTEs versus incidental VTEs. So VTEs that are being picked up incidentally, likely during screening CT scans, and these patients were eligible to be enrolled. When we look at the Kaplan-Meier curve here, looking at the cumulative event rates for recurrence, specifically recurrence within the 6 months, we note once again that there were less recurrences with the rivaroxaban group versus the dalteparin group. And on the next slide, we see exactly that at the 6-month mark, the rate of recurrence of VTE was 4% in the rivaroxaban group versus 11% in the dalteparin group, for a hazard ratio of 0.43, but as a result of the small sample size, the confidence interval is quite wide, from 0.19 to 0.99. When you break down the types of VTE or PEs, we note that a small group, in this study, splanchnic vein thrombi were also included in the primary outcome, and there were 2 of these in each group, the rivaroxaban group and the dalteparin group. But overall, you can see that rivaroxaban was associated with a relatively low rate of recurrence of VTE at around 4%. When we look at major bleeding and looking at the Kaplan-Meier curves, once again for major bleeding, we see that major bleeding is quite distinctly different between the dalteparin group and the rivaroxaban group, and we note again that it seems to be that there is more major bleeding with the direct oral anticoagulant, in this case rivaroxaban, as compared to low molecular weight heparin, or in this case dalteparin. So we see major bleeding was 3% in the dalteparin group versus 5% in the rivaroxaban group, and that there was also distinction to be made between dalteparin and rivaroxaban when looking at clinically relevant non-major bleeding, 3% in the dalteparin group versus 12% in the rivaroxaban group. So there was more bleeding in total in the rivaroxaban group versus the dalteparin group. And when we see that, once again, the story of GI bleeding comes through. Most of the major bleeding events were gastrointestinal bleeding. No CNS bleeds were noted. And moreover, most of the clinically relevant non-major bleeds were gastrointestinal or urologic. Once again, survival was noted, was also determined, and the survival in this study was 75% in the rivaroxaban group versus 70% in the dalteparin group. So overall, 26% of patients died, and 88% died because of progressive cancer, 2% because of fatal PEs. Now, these are the 2 studies that have been to date published and have specifically looked at comparing a DOAC versus low molecular weight heparin for the management and treatment of acute cancer-associated thrombosis. And just this year, we had a systematic review and meta-analyses put together that combined the risk estimates from these 2 studies. And in the top panel, we look at both studies, the RASCOP study being the Hokusai Cancer VTE study and the Young study being the rivaroxaban or SELECT-D study. And when we look at panel A, looking at recurrence of VTE, and panel B, looking at major bleeding, we see the same story come through, where there seems to be a decreased risk of recurrence with the direct oral anticoagulant, but more major bleeding with a direct oral anticoagulant, or a safer profile when looking at major bleeding for low molecular weight heparin. So that is sort of the, before I move on, the totality of evidence thus far published that looks at the initial therapy for cancer-associated thrombosis. Several studies have been done looking at low molecular weight heparin versus vitamin K antagonists. And in the last year, we now have the direct oral anticoagulants being compared to the standard of low molecular weight heparin. We'll touch base at the end of this presentation and comment on what the significance of this is vis-a-vis the day-to-day management of cancer patients with associated thrombosis. But before we do that, we thought we'd also sort of talk a little bit about issues vis-a-vis the management from an inpatient versus outpatient perspective of these patients who present to hospital. And a question often is asked is when to hospitalize a cancer patient who presents with, for example, pulmonary embolism. And it's important to note that many factors come into play when making this decision. First and foremost, it depends on the severity of the pulmonary embolism, and estimating the risk of adverse outcomes is therefore quite important. Although we do not have specific scores or prediction models to help us determine who is safe to discharge home for a cancer patient who has a complication of an acute thrombi, we do have scores that have been developed to determine mortality and adverse outcomes in patients with venous thromboembolism in general, and this is the Pulmonary Embolism Severity Index, and there is a simplified version called the SPESI, and these have been widely validated to be able to adequately determine adverse outcomes and mortality at 30 days for patients presenting with acute pulmonary embolism. I'll show the two scores on the next slide, but most of you'll see the factors that go into this score are clinical-based and patient-based, but there is ongoing work looking at biomarkers and adding biomarkers to these scores, including, for example, troponin, BNPs, pro-BNPs, and so on, as well as echocardiography parameters that could further refine the risk score. And there's some work being developed looking at specifically in cancer patients. But having said all this, we and others have shown that there is in Canada and in Europe an increasing trend to the outpatient management of pulmonary embolism, and likely instigated or at least facilitated by the important pressure on our healthcare system to reduce the strain on our inpatient resources. And although it may not be so clear to see, you can see here the PESI score and the SPESI score. The simplified score has been shown to work just as well as the PESI score in determining risk of death and adverse outcomes at 30 days in a patient who who presents to emergency room with pulmonary embolism. And you can see simply that these are mostly patient-derived factors and clinical factors, and there are no lab parameters that are included here. We'll get back to this score when we apply to one of our cases at the end of this talk. So When we move on, I want to talk about, in the next few slides, the summary and key learnings that we've had from the low molecular weight heparin versus DOAC for the treatment of cancer-associated thrombosis. I think the data is quite riveting and quite important, and actually helps further and refine the treatment of cancer-associated thrombosis. But there are specific clinical considerations that have to be taken into regarded when managing a patient, as well as the patient's considerations. I think one of the messages coming forth is that we need to really be tempered in our use of direct oral anticoagulants in patients with gastrointestinal cancer and potentially patients with uroepithelial malignancies, given the trend we're seeing in both these studies of a GI signal for bleeding, and that this is mostly in patients with GI malignancy, and the signal we're seeing for clinically relevant non-major bleeding being primarily including patients with GU malignancies. I think the other consideration here is the special patient population, specifically patients with renal dysfunction. As you saw, there were very few patients with creatinine clearance between 30 and 50 mils per minute that were included in the Hokusai Cancer VTE and SELECT-D studies. So I think with patients that are nearing in this realm of 30 mils per minute and below, we have to be quite careful in the use of direct oral anticoagulants in this patient population. And perhaps our historical experience with low molecular weight heparin, although we don't have large randomized trials to inform their use in cancer-associated thrombosis, we do have smaller studies which provide us with some data to provide some comfort or at least experience in prescribing these medications when dealing with renal dysfunction. I think we also have to be quite careful when considering drug-to-drug interactions when choosing a direct oral anticoagulant. For example, in the Hokusai Cancer VTE study, patients who were taking medications with the glycoprotein, GP glycoprotein, and with GP glycoprotein inhibitor potential were not included. So it would be very important because this would either impact on the bioavailability of the direct oral anticoagulant, either high or low, either increasing the risk of bleeding or decreasing the anticoagulant effect of the direct oral anticoagulant. So I think these need to be well thought of before prescribing a DOAC to a cancer patient, and that can simply be done with consultation with your pharmacist and having a good idea with your oncologist of the different medications or cancer chemotherapeutic agents that your patient is taking. I think high-risk bleeding is something to be wary of. We saw that there's although in Hokusai Cancer VT, the primary outcome was a composite outcome, and major bleeding itself was just a secondary outcome, the signal of a higher bleeding risk needs to be considered, especially when dealing with patients who have a prior history of major bleeding or have thrombocytopenia or any other risk factor that can increase their baseline risk of bleeding. And the current cancer treatment needs to be considered as well. Are we using agents that can, for example, induce severe mucositis or enteritis, and that makes me wonder about the risk of bleeding as a result of that. And if it's going to be enteritis or mucositis, that is a GI potential source for bleeding, which needs to be considered when you're contemplating which medication to use. And finally, obviously, patient considerations need to be considered. Patient preference, it has to be, it most often is assumed that a patient will prefer oral versus an injectable, but at times an injectable may be something that is preferred, especially if issues with gut absorption or malaise, nausea, vomiting that can be occurring during cancer chemotherapeutic management, and so it may not be as easy to go forth with an oral medication. Insurance coverage is important when determining which medication to use. Some of these new direct oral anticoagulants are not yet on the different provincial formularies. The story may be different province to province, but for example, edoxaban is not on any provincial formulary as of yet, and so patients will need to have private insurance if you were to provide this medication or preferentiate edoxaban over any other medication. And extremes of body weight, we really don't have much experience with DOACs in extremes of body weight, so above 120 kilos or less than 60 kilos, and so that needs to also be considered. So these are some of the drug-drug interactions that can either induce or inhibit the P-glycoprotein mechanism of drug availability, which is a gut transporter in the intestine, or the hepatic mechanism of metabolism using the CYP3A4. And so you note here that the DOACs depend on these two mechanisms for metabolism, some more than others. So for example, edoxaban is primarily, does not depend much on the CYP3A4. So any of these chemotherapeutic agents that impacts on the CYP3A4 would not be really an issue with edoxaban, but it can be an issue with, for example, dabigatran or even rivaroxaban. So these are theoretical, presumed type of possibilities that could happen with the different chemotherapeutic agents that are noted here, and should be considered when looking at prescription of a DOAC in the context of these medications. Patient preference, as we talked about earlier, are noted there again. I won't go over this again, but I discussed it in the previous slide. And preventing recurrence patient education, I think, needs to be highlighted. Risk reduction strategies only work if your patient's engaged and informed. So risk recurrence after a first episode of VTE is higher in cancer patients than in those without underlying malignancy, and that's something I'm always telling my patients who have cancer, and I'm seeing them in the clinic so that they can understand that we're in for a long-term therapy because we're thinking about reducing the next clot. Adherence to anticoagulant treatment plan is important, so I do emphasize the importance of keeping to the therapy. It can be very difficult when these patients also have to undertake many other types of medications for their cancer treatment, and the focus often is on the cancer, and often the thrombotic complication may not have such relevance for them depending on where they're at with their cancer therapy. I review reasons for the anticoagulation. I think it's always surprising to my patients that the anticoagulant is not there to really dissolve the clot that has occurred, but rather to prevent extension of that clot and to prevent new clots or more clots from forming anywhere else. So that's always quite surprising to the patients. I also highlight, again, adherence and compliance. And we look at their medications when they come to our medical appointments and figure out how much the patients have been taking. And often they'll come to me, oh, I don't need a prescription, and it's been 6 months, and I know I only gave the patient for 2 months. So one wonders how these patients are following instructions. And we always review appropriate injection techniques. Also, these are some of the things you can go over with your patients: signs and symptoms of DVT and PE. Often it's surprising to patients that if they presented with a DVT, explaining to them that a recurrence could be a pulmonary embolism and not a DVT next time. And so it's important to go over the symptoms of PE, for example, in that case. And also reminding patients, we often forget this, but we should also remind them of the adverse events that can occur with an anticoagulant. Often they're more concerned of these medications causing, for example, hair loss, liver problems. I've even had people thinking that it'll bring on a new cancer because they're going to be on this medication for a long time, and can it interfere with their chemo and give them more cancer. So usually I deflect and focus on the main complications and the serious complication of major bleeding, and often go through the different signs and symptoms that they should be aware of. And here we engage our patients on the various risk factors and preventative measures all the time. We make informed decisions in partnership with their other healthcare providers. We aim to address patients' individual needs and preferences, and use a lot of patient education materials that you can also find through any society, especially Thrombosis Canada online. On their website, they have a lot of great material you can use with your patients, both in English and French. And here we are, and the website is noted there. And there are also videos available online from Thrombosis Canada. So before we go into our cases in our last half hour, I'll pause to see if there are any questions. We have a couple of cases to go through, or you may want to bring up your questions at the end. Vincent. Vincent is asking, now let me figure this out. Where would the question be? Because it disappeared. Oh, here we go. From Vincent, I'm not sure if I've missed a part regarding the usage of low molecular weight in renal decyclide. It is not recommended lower than 30 mL. In hospital, they may use heparin for those severe renal patients, but it would not be feasible in our outpatient center. Would you mind clarify that or elaborate on that? Perfect. Yes, Vincent. So in general, below, you're right, correct. As a general rule, with creatinine clearances less than 30 mL per minute, especially when admitted to hospital, where potentially there's big fluctuations in creatinine clearance because of ongoing issues requiring hospitalization, and patients can easily come in with 30 mL per minute, and by 48 hours could be even worse than that. We will often use unfractionated heparin, but there is quite a bit of data to show that based on both non-clinical outcome data, meaning looking at anti-10A levels, and some short duration usage of low molecular weight heparin with patients with impaired creatinine clearances down to 30 mL per minute, but not using it more than a couple of weeks, we see that bioavailability studies and clinical outcome studies show that with some of the low molecular weight heparins that have been done, that it seems that bleeding risk is not elevated. And so sometimes in an outpatient setting, I'll manage to use low molecular weight heparin even down to 25 mL per minute with low molecular weight heparin and using anti-10A levels, for example, if they're available in your institution, to follow patients during the course of treatment. Obviously, these are patients where I am comfortable doing this when there are no other concomitant reasons that the patient could potentially have a depressed renal function. So, for example, they're not taking any nephrotoxic other type of medication, they're not on an aminoglycoside, they're not taking another antiplatelet agent that could increase, or a non-steroidal anti-inflammatory agent that could further impair their renal function. So you're right, probably in an acute care situation where the patients are being admitted to hospital, unfractionated heparin is likely the best option when dealing with low creatinine clearances. But in an outpatient setting, there is some data, especially with low molecular weight heparins that are not as dependent on less dependent on renal clearance, that you could easily, if you follow your patient closely and use anti-10A levels, and at least in a short duration period, can manage these patients safely. Okay. From the renal, Norma. Great. Okay, I think we'll move on, if that's okay with everyone, and we'll explore perhaps this further in the next few slides that we have in the remaining half hour. I just have a question from Emily, apixaban in cats. So Emily, that's a good question. So far, there is a trial ongoing comparing apixaban to dalteparin in cancer-associated thrombosis. The trial is called Caravaggio. It's entirely based on sites in Europe, and it's actually probably, I think, 3/4 of the way through. So we hope, I think they'll finish enrolling next year in 2019, but so we won't have data on apixaban until at best later in 2019 or in 2020. But we're also, like you, anticipating that, those results. Okay, so I think I'll move on. Case studies. So we'll go through the first, great, thank you, Norma. I think I'm gonna, who's provided the link to Caravaggio. So I'm gonna close the chat box because it can be very distracting. So the first case study we have is, I believe we have 2 or 3 cases. Norma will keep me on time. Hopefully we'll get through 1 and hopefully 2 in the next 20 or so minutes that we have. So the first case is a metastatic colorectal cancer. Okay, so this is Miss R.S. She's a 54-year-old high school teacher, married, mother of 2 adult children. Her past medical history is significant for hypertension and hypercholesterolemia, both well controlled with appropriate medications. Her BMI is 31, noted there, and her laboratory investigations would include, which include a CBC, lights, renal indices such as urea and creatinine, and liver function tests are all within normal limits. So this is a case of metastatic colorectal cancer, and she's receiving palliative chemotherapy, FOLFIRI and bevacizumab in a stop-and-go fashion for 2 years, and she presents with painful, swollen, and red lower left limb. An ultrasound confirms a proximal deep vein thrombosis of the left popliteal vein. So, question to the audience, is, what would you do? How would you treat Mrs. RS, and why do you choose this option? So these are the various options available to you. You treat with dalteparin only. You treat with edoxaban only. You treat with tinzaparin only. You treat with low molecular weight heparin for 5 to 7 days with transitioning to warfarin, and you treat with low molecular weight heparin for 5 to 7 days, then switch to edoxaban, or you treat with rivaroxaban only. So once again, this lady has metastatic colorectal cancer, and she's developed a DVT. She's receiving palliative chemo, and these are 2, 4, 6 different options that can be used. Do we have folks for, let's see, answers, anyone? Are there folks who would, let's see, still consider warfarin for the management of cancer-associated thrombosis? Okay. I guess they will call me. Yeah, great. Well, I think there's no right or wrong answer here vis-a-vis some of the options. Oops, I'm just going to go back. The low molecular weight heparin could easily be used in this patient, and the options are there. As well, I think the usage of warfarin is something that is considered to be second line as per many of the guidelines, and not something that one would see is a first option. I think the fact that there is this signal of a GI bleeding tendency, moreover, the GI bleeding tendency is seen in patients with a GI malignancy, at least the evidence so far is pointing in that direction. And irrespective of the patient having an upper GI or a lower GI, one could think of using a DOAC, but given the evidence to date that perhaps GI bleeding may be significantly different with edoxaban or rivaroxaban compared to, for example, a low molecular weight heparin, then perhaps I think in this case you could theoretically consider this and you know, think of perhaps preferentiating a low molecular weight heparin in this case given the underlying malignancy. Now, it doesn't mean that if she's going to be getting the type of chemotherapy she's getting, and perhaps the risk of enteritis or colitis or mucositis is quite low, then periodically, at least initially, you may want to consider a direct oral anticoagulant. But at this point in time, I think it would be reasonable to perhaps think about low molecular weight heparin here. I don't know if anyone has what other best way to reach out to folks if they want to discuss this further. But if there are no specific concerns with this type of management, let's see what happens next. So here, her renal function is decreased to a creatinine clearance of 29 mils per minute. So we just discussed quite adamantly about the safety of any real anticoagulant with creatinine clearances below 30 mils per minute, with the exception of warfarin. All the different anticoagulants do depend on renal clearance to some degree, others more. So the direct oral anticoagulants, as you know, are quite dependent on creatinine clearance or on renal elimination or mechanism having an clearance through a renal system, and in cancer patients specifically, where often you are faced with nephrotoxic agents that can be given, even at creatinine clearances between 30 and 50, you have to think about it and follow your patient closely when considering using a direct oral anticoagulant. We don't have great data to inform us, and it is quite controversial as to how best to treat patients with creatinine clearances around 30 mL per minute who have cancer and an acute thrombus and are receiving different chemotherapeutic agents where there's a potential impact on worsening renal function and can be on other concomitant medications that can induce thrombocytopenia, for example, further increasing the risk of bleeding. So when you're dealing with this, I think certainly I don't have much experience using edoxaban or rivaroxaban in this patient population at creatinine clearances of 30 mL per minute. Most of my experience is with low molecular weight heparin at this level of creatinine clearance, and most of my experience has shown me that these patients are outpatients, continue to be outpatients, often difficult to manage with Coumadin, especially if they're going to be getting GI-induced mucositis or enteritis with their chemotherapy. And so often the course is either going to be, which makes Coumadin difficult to manage, and so often it is going to be that option versus close follow-up with low molecular weight heparin. But really, if I have anti-10A surveillance, then that is something that I often will do. I have been known to use Coumadin as well when dealing with such low creatinine clearances. But certainly, if you poll different thrombosis experts or specialists, hematologists, oncologists who treat these patients on a regular basis, you'll get a varied response. Okay, next. Oh, here we go. So from Emily, would there be one reason to give dalteparin versus enoxaparin versus synthoparin is the renal elimination? Yeah, so the renal elimination is not the same for each of the low molecular weight heparins. So you would have to consider the renal pharmacokinetics for these medications in determining how best to proceed. And moreover, you do have also the option of, which I haven't mentioned before, is that unlike the DOACs, you do also have the option of decreasing the dose since it is weight-based dosing, and that can also impact on your renal elimination. And the other question is, how often do you check anti-10A? So I generally will check when I start the patient in the first, upon starting them with low molecular weight heparin, I will check in the first 72 hours of initiation, and then I'll do it 1 week later. And then usually I see these patients on a monthly basis, given that they're coming in for also their oncology appointments, and then I'll be checking once a month. Given that this is a very volatile type of patient population vis-a-vis renal function, I do this in non-cancer patients where the follow-up is not as frequent or every month. Okay. Next. And so here we have renal function surveillance for creatinine clearance less than 50, especially in the cancer patient population, as we've already discussed. Therapeutic doses of low molecular should be avoided in case of severe renal disease unless monitoring by anti-factor 10A heparin levels, and that's something I certainly do in my practice. And I should note that I don't do it with all patients, especially if I feel the creatinine clearance may worsen acutely because of what patients are being given vis-a-vis their chemotherapeutic agents. So it does require a lot more vigilance and a lot more close follow-up of their care, which often may be, I may have mentioned earlier, quite difficult to do. And so it is something that has to be taken extremely well thought out with good surveillance and good follow-up. And then, of course, in patients in end-stage renal disease requiring dialysis, then I think there's really low molecular weight heparin is not something that I use in these types of patients. There are some preliminary data that suggests that it can be used with extreme care, but I think it's something that needs to be addressed case by case, and certainly not something that can be advocated on a general basis. So then we move on to low molecular weight heparin in patients with CAS and renal insufficiency. This is some of the data we had asked for patients with that I had alluded to earlier. Both the CLOT study and the CAS study have provided some subgroup analyses or post-hoc analyses since the publication of the original studies that have gone out to look at this issue of renal insufficiency. The CLOT study looked at creatinine clearances less than 60 mils per minute, and you note there when they compared at the top looking at VTE, where you see variable, and below that looking at major bleeding, comparing dalteparin to vitamin K antagonist. In these patients, there wasn't a difference, statistically significant difference, when looking at major bleeding, where the dalteparin group experienced a 9.5% major bleeding risk, and the vitamin K antagonist experienced a 6.9% major bleeding risk for a hazard ratio of 1.29. Now, that is only 161 patients, and this was a secondary post-hoc analysis. But this is what I was alluding to earlier, that there is some data at least to suggest that perhaps the major bleeding is not that different between the two. And moreover, when they looked at venous thromboembolism recurrence, they note that the risk of venous thromboembolism was certainly, as in the original analyses, there was less recurrence with the dalteparin group versus the vitamin K antagonist group, 2.7 versus 17.0%. And when they looked at the CAS study, so now the CLOT study was less than 60 mils per minute with very, very, very few people below 30 mils per minute. When you look at the CAS study, they looked at creatinine clearances between 20 and 60. They had a fair, some more people, slightly more below 30, but most patients were between 30 and 59 mils per minute. And they also showed no statistical significant difference between tinzaparin, because the CAS study looked at tinzaparin versus vitamin K antagonist when looking at major bleeding, 8.1% on the vitamin K antagonist group versus 4.3% in the tinzaparin group. And they had a little less, few people, 131 patients. And similarly, venous thromboembolism was not statistically different between the two groups. And I should say, for all these studies, anti-10A monitoring was not something that was noted to be done consistently or for all the sites or for every patient. And so this was not data that was reported or captured. So it's unclear whether anti-10A monitoring was used as part of this, as part of the management for these patients. Okay. So I'm just going to open up Okay, so what if she was receiving adjuvant FOLFOX chemotherapy and her platelets were chronically in the 75 to 80 range? So here we have this patient who has a chronic thrombocytopenia in the 75 to 80 range, and undergoing chemotherapy potentially is going to drop those platelets further. And so the bleeding risk is now heightened and needs to be considered when managing this patient with cancer-associated thrombosis. So do we treat with dalteparin only? Do we treat with edoxaban only? Do we treat with tinzaparin only? So the same options are available again. And it's very difficult to know what to do. Certainly, once again, we are in in this era now with the direct oral anticoagulants just starting to gain some experience in the cancer patient population, nonetheless, but we still have very few data to inform us as to how these drugs fare when we're dealing with thrombocytopenia. We seem to have a little more experience with the low molecular weight heparin agents only because they've been around a lot longer, and we've learned to be able to use these medications in these different situations or special clinical situations that are not easily informed by clinical trials. So if we look at anticoagulation and thrombocytopenia, heparin-induced thrombocytopenia, obviously, when a patient who is on an anticoagulant comes to my clinic and now the platelets have dropped, you have to be able to consider that heparin-induced thrombocytopenia must be in the differential and excluded in patients if anticoagulant therapy is to continue in a safe manner. And this will not be a talk that will focus on heparin-induced thrombocytopenia, but we just highlight that it needs to be considered. But in the presence of thrombocytopenia, one needs to do a risk-benefit balance of anticoagulation once again, and it should be noted at first that we all agree that the risk of VTE recurrence is particularly high in the first 3 months after thrombosis. And as a result, if we all agree on that, and there's very good epidemiologic and trial data to show that the risk of recurrence is highest in the initial period following an acute venous thromboembolism, then it behooves us to be able to at least attempt to continue anticoagulant therapy during this period of time so that we can offer safe administration of anticoagulants. So I think what I'll do is I'll quickly show you what needs to be considered, and this is the algorithm that has been proposed by the SSC of the subcommittee of the ICH that has looked at thrombocytopenia in patients with acute VTE, and we note that when dealing with platelets below 50, and we're in the first month of an acute venous thromboembolic event, the goal is to continue with anticoagulant if we can by maintaining platelets with platelet transfusions to maintain them above 50 with therapeutic doses of low molecular weight heparin. However, it's noted that this is not always possible, and if we can't be able to maintain our platelets, then if our platelet range is between 20 and 50, consideration should be made at decreasing the dose of low molecular weight heparin by 50% and less than 20 to hold the low molecular weight heparin dose. And here we have the ICH-SSC that tells us what to do, what they suggest in guiding us beyond the 1 month, so after that first 4 weeks where the risk of recurrence is not as high, and at that point, if our patients are with platelet counts between 20 and 50, we can consider using an intermediate or a prophylactic dose of low molecular weight heparin, and below 20, it's suggested to not use low molecular weight heparin. So I think we have gone through a lot of material. The hour is up. The last case is available to you, and you can look through it. And I'm sure David will reach out. You can reach out to us for if you have any questions or concerns and would like clarification on some of the later cases that are presented. Unfortunately, it's a long sort of presentation with going over carefully the data in this area. And the great thing about this program is that we do individualize some of the concerns according to cases, and you may be able to identify with some of these patient populations in your own clinic. I hope it's been useful to you, and please do not hesitate to reach out to our organizers, and we can perhaps answer your questions if you do have some questions at a later date. And I want to thank David and Normand for all their help in launching this tonight.
And thank you, Vicky, for your great presentation. I hope that you everybody's enjoyed this evening's program and found it valuable with their time. Again, as Vicky said, please send any questions to us, info@Thrombosis Canada, or and also watch out on our website. We will have a copy of this presentation available for download when we have archived the presentations that are happening this week. And again, thank you very much for your time.
Thank you, everyone.